From the 6th of January, the vaccine for conditions for deployment regulations came into place, which basically means that if you work in the NHS or social care, you effectively need to have had your COVID vaccination. In this episode, myself and Andy are going to go have a look at the guidance that came out that explains this whole process in terms of what that means for staff and also for employers, what this may mean for your practice or organisation, and the different options you've got available. Very clear, we're not HR experts, but we're going to try and demystify this for you to help make it a lot easier for you, your practice, and your patients. Let's tech enhance your primary care and learning. Hi, Andy. How are we doing there?
I'm good, thank you. Just joined the stream in the nick of time. I'm here at the Bulwell Riverside Joint Service Centre Vaccination Clinic this morning. We've just been visited by Alex Norris, our local MP, and Nottingham television cameras. So I've just finished with them and dashed into the studio with you. How are you?
Yeah, not too bad. So as Andy mentioned, we're doing a bit of a jumble kind of a live stream here because Andy's actually coming live from a vaccination centre. And we've been preparing some information to share with you about this whole concept of vaccination mandate, as probably more people are aware of it as. But in terms of the guidance document, it's called the Vaccination Conditions for Deployment, which we're going to go through in a second. We're going to put on screen. Just like to start this live stream with a slight preposition that obviously myself and Andy are not HR experts. We are not commenting on whether this is a correct way for the government to make a decision in terms of mandatory vaccinations for employment and stuff. We're going to stay away from that particular debate topic. We're just simply going to go through the guidance that's available and give you our interpretation of that guidance, what that might mean for practices, for staff and for patients. Any questions on that, Andy?
No, not at all. That sounds really good. And let's go ahead.
Okay, dokie.
Actually, I was just thinking, Andy, so this has been quite a hot issue because I know I was I did a TV not TV. I was on East Midlands radio, Nottingham radio on Monday morning, and I thought I was going on to talk about vaccine hesitancy in the general population and to encourage people in my area to get vaccinated. But they asked a lot of questions about this, what we call VCOD, isn't it? Vaccination of condition of deployment. So it's been a really hot topic in the media as well.
Absolutely. And similar to yourself, so I was on Kemet FM on Wednesday talking about the COVID vaccinations, and absolutely the discussion got dominated by this topic. And basically, as I said, we're going to go through the guidance and the documents and try and demystify this for you as much as possible. This is hopefully going to be really relevant for you to share with your staff to give a description of what the responsibilities are from both sides, both employers and from the employees, and also where some of the guidance and stuff comes into play. So we've got a lot of this prepared for you already on the stream. So I'm just going to bring up some documents for you all to have a look at. All the links to these documents are in the show notes on the YouTube channel, and if you go on watching on Facebook and stuff, have a look on there. If you're listening to us on the podcast, again, all the links to this will be in the show notes of the podcast itself, so do have a look and stuff from there. So the main document we're going to have a look at is this vaccination as a condition of deployment document that you can see here, or as we're going to be calling it, VCOD from now onwards. I must admit, the first time I heard this acronym, I thought it was somebody jumbling up COVID because it kind of sounded like that. But obviously, this is talking about this condition of deployment and stuff. And there's two documents that have come out from this. And this is an iteration from the phase 1 document, which came out back in November, I believe it was. So if we have a look at the first main letter, which is this one. So this is the summary letter. As many of you probably had a look at some of our streams and that kind of stuff, will probably be aware there tends to be a kind of like summary letter that's really short, and then the fuller guidance, which is a lot longer. Summary letter is 5 pages. And the first thing I'm going to say about this, look at the list of who this has gone to. I think this is pretty much everybody working in the NHS, as far as I can tell. That is a massive list of people in terms of organisations. What are your thoughts on that, Andy?
Yeah, I mean, as it should be, really, because this mandate does have quite wide-reaching consequences, and it does touch every part of the NHS. Well, I'm sure we'll get to the type of staff and the type of activities that are covered, but it really is really wide-reaching. So I think that's a long list, but I guess not surprising given the content.
Absolutely. So the main letter makes a description of the changes in the Health and Social Care Act that have taken place. So this is basically the changes in law that have made this a mandate effectively. So these came into effect on the 6th of January. And if you want to have a look at the actual law changes, I've got them somewhere here. I did have, apologies, I seem to have lost them, but I can try and find them out again somewhere. So the link is in the show notes, but the actual link to the change in the Health and Social Care Act is there that basically makes this into effect. One of the key things that's really helpful to have a look at, and I will enlarge this for you all, is this timeline that you can see here. So as you can see, the grace period that we're going to talk about briefly came into effect on the 6th of January. The key one for most people watching this live stream right now is a date that's in 11 or 12 days time, which is the 3rd of February, which is the last date for those that are not vaccinated to have their first dose in order to be within the guidance. And the key other date is the 1st of April, where these regulations come into law and come into force in terms of being vaccinated with regards to working in the NHS and social care if you have a patient-facing role. Any comments on that lovely diagram there, Andy?
I mean, 3rd of February feels pretty close, doesn't it?
Yes.
I guess. Although organisations have known about this for quite some time, or at least since November, so there's been a bit of lead time. But we're very close to that now, hence all of the interest, I think, really. And there's a bit of a scramble at the moment to try and get people vaccinated and have those conversations, as I'm sure we'll get to, around the implications of not being vaccinated and what that might mean for people's roles. Just reflecting this morning, I'm at the vaccination centre, and the people here are telling me that they're seeing quite a lot of healthcare workers actually coming forwards for first, second, or booster vaccinations who haven't presented before. So I think people are being reached by this message now and the urgency, and a lot of people are getting vaccinated. Reflecting on that.
Yep, and I think obviously this document and this mandate is going to make people want to decide on that decision fairly soon, because obviously we do know that the 3rd of February is the last date that you can have in order to be vaccinated by the 1st of April to have your both doses. Just to be clear, the documents do state it's about having 2 doses of your vaccinations, if that's with Pfizer or the other UK-based vaccinations. There's some allowances if you've had vaccinations from abroad, depending on how many doses you need to have. But effectively, for UK-based current vaccinations, it's the 3rd of February is the last date. The letter then outlines 4 other pieces of information for reference. So the main one, which is the one that we're going to be going through, which is the Phase 2 VCOD Implementation Guidance. So we're going to have a look at that shortly. There's a really helpful frequently asked questions, which again, we're going to review. And that's probably where I would direct most people to have a look at if you don't want to go through the entire document, but you want a bit more information. There's a piece about VCOD workforce vaccination history solutions. So this is more for managers and employers, so they can cross-reference information about people's vaccinations with the NIMS database, which is all the information about your vaccination is stored, versus the staff records and things. This has caused some consultation because it's the concept of about access of data and things, but they have outlined in the documents why they've taken the steps to make this available. And it's only certain people within an organization that will have access to this. This won't be everybody. And then lastly, it talks about repository of information on the FutureNHS platform, which many people use for storing and sharing information across NHS. Just to give you a brief look at that, this is kind of what it looks like when you log in and stuff. And this is just the main dashboard page, but there's no other kind of information there apart from the key dates that we've already mentioned and stuff. And then that's effectively the main letter. There's a bit more description it gives for some of the stuff, especially the vaccination information solution. But what we're going to focus on now is actually the key part, which is the implementation guidance, which is this one. And it is pretty impressive. It's 24 pages, Andy.
Yeah, good. I'm buckled in and ready to go.
Okay. So I've created a slightly different version, which is a document version here. So it will look slightly different compared to if you're looking on your computer, but this is just we've highlighted some key points and things. The first start, as ever, is an introduction that gives the background for what people need to be aware of. And it talks about the guidance, why this is coming to effect. And obviously the key point it mentions in bold is this 1st of April deadline in terms of the actioning point of the regulations. Then talks about the purpose of the guidance and that they did have a phase 1 guidance, which you're more than welcome to have a look at. It's a little dry, if I'm being honest. But this one is the more pertinent information. Also talks about who the guidance is directed at, and as we saw that massive long list of people at the start. And I'm going to start off with this key one, which is the definition of who this is relating to. So a key message in the phase 1 guidance: the responsibility of the registered person is to employ or otherwise engage a person for the provision of a CQC regulated activity who has a face-to-face contact with patients or service users. So that's the key part where this applies for. So if you have any face-to-face contact with patients, service users, whichever term you use, this applies to you. That includes receptionists, that includes admin, and which were you going to say, Andy?
Yeah, I was just going to ask for your interpretation of it, and we may get to it later, but there are some useful sort of flow charts in I believe this document or the FAQs, and it was very interesting to see that sort of even if you're an admin person whose general day-to-day role doesn't necessarily involve face-to-face contacts, but you are operating from a building where those occur, and you might bump into a patient in the corridor or one of the flow spaces, then it was interesting to see that the guidance applies to those roles as well. Just checking that that's your interpretation, but that seemed to be quite clear, which was surprising. So it's almost anybody who works in a healthcare setting, unless they're in a sort of separate administrators building or area with separate entrances to patients. So it really is really far-reaching.
Yep. So the other one that I picked up on was whether that would apply to cleaners, for example, who wouldn't really normally have any patient-facing activity. My understanding is if you're a cleaner that works during the times that the buildings are open, so you may potentially have contact with patients, then you would need to be, this guidance would apply to you. If you are solely working out of hours when the building was shut and have no absolute contact with patients, that might not apply. But again, that's just our interpretation of what it says here in terms of the guidance and stuff and things.
Yeah, and also, Gandhi, just to get into the weeds, practice maybe in a situation, perhaps in a joint service centre, where the cleaning is not provided by their own staff, but subcontracted to another provider, who may then further subcontract to another provider. And of course, the regulation and the penalties are targeted at the employer, where they are a healthcare employer, and just tracking that back to actually, are there penalties and who are they for if those subcontracted cleaners are not vaccinated? It's difficult to pick that apart, and I was struggling to find a solution within the guidance. I don't know if you had any more luck than me.
No, it doesn't go into that kind of detail as to what happens if you subcontract services out to other companies. My understanding would probably mean that either you would need to find an alternative company to provide that service, or that those regulations would still apply to those companies if they provide that service, because I imagine they would have to have some sort of registration process. Don't forget that the arbitrator of this is CQC. So it is relating to healthcare provision in that respect, and it talks about that a little bit later on in the document.
I guess people can ask questions of CQC. An important point is actually where do people ask their questions if they have these situations not covered by the guidance.
Yeah, my understanding is it's CQC that's going to be making the decision as to what impact this has. So if you do have any questions, it would be directed towards them potentially. It talks about the aim of this is to protect vulnerable people and individual workers in the health and social care settings, such as practices, dental surgeries, community services, and hospitals and things. And this is probably one of the key things. So it's delivered through anybody that has a substantive, seconded, or fixed-term staff bank and agency workers, contractors. So we talked about that briefly. Volunteers, locums, honorary contract holders, students or trainees, or any other type of worker involved in the provision of CQC regulated activity with direct face-to-face contact with patients or service users.
So that sort of answers the question, actually, doesn't it? It appears intended to apply to anybody working in that shared space with patients. I suppose the tricky part is making sure that your agency staff that you don't manage, who are providing your cleaning service, are vaccinated, and how you get access to that information to provide you with assurance. It's difficult, isn't it?
It is. I guess that then leads on to the question, who does this not apply to? So there are some exemptions. So first of all, if you're under the age of 18, this does not apply to you. However, later on in the document, it does state if you've got somebody who's coming towards the age of 18, you do need to have these discussions with them, because they will come into force when they turn 18. So important to be aware of that. If they're medically exempt, so this is based on the government's Green Book in terms of whether you have the exemptions. And again, we'll come to how that's applied later on. And if you've been part of a COVID trial, so there is an exemption if you've been part of the trials themselves. Then there are some temporary exemptions, of which the main one that probably be applied to most of the NHS staff is whether or not you may be pregnant. And again, there's an element of exemption until you're 16 weeks after birth, after which the guidance comes into effect and the regulations do come into effect if you're not vaccinated at that point.
Can I ask a question? Just a question on that one, because this one sort of confused me a little bit in terms of its intention, because obviously the strong messaging around vaccination in pregnancy is that people should get vaccinated in pregnancy. And I just thought the inclusion of this exemption clause might confuse people a little bit. And perhaps, when you put that point next to, pregnancy next to the other medical exemptions, which are when we wouldn't advise people get vaccinated, it just feels like that might confuse things a little bit. So I thought that was interesting. Any thoughts on that?
So I give my opinion. So you're correct that the general advice is that even if you're pregnant, you should be vaccinated, because we know that the outcomes for the mother and for the child can be fairly disastrous if they were to contract COVID and that was to have complications as a result of it. So the general advice is still to be vaccinated. However, I think there is that element that they can't force people to have a vaccination whilst they're pregnant, because of the potential risk that some people feel that there is, and it's that element of regulation, because obviously they can't really go around testing it on pregnant women. It's a bit trickier to do that. So because of that reason, there is that temporary exemption. However, like I said, it's a temporary exemption that the moment that you are 16 weeks post delivery, that element of exemption for the pregnancy is no longer in effect, and therefore that's why the regulations kick in again at that point. So really important to be aware of that it is a temporary exemption only. Does that answer your question?
Yes, it does. That's good. I just thought it was confusing, and also I think I'm just thinking about the reasons for it being there, and I guess people are particularly worried, and questions around choice are particularly pertinent, I guess, during pregnancy, and
possibly
that's probably the rationale behind that. But there we go.
Yep. And then there's those that are not in the scope of VCOD, so those workers who don't need to be vaccinated in that way for whatever reason and stuff. So there's comments about employers being proactive in this and, looking about taking action with subcontractors and stuff. So we talked about that, and having enough vaccine available. So some of these are sensible things that you can imagine about basically having these early discussions and stuff. And then again, we see the deadlines that we talked about earlier. Important to note, the first deadline of the 6th of January, when this starting, it did suggest that many organisations should start to have these early discussions with staff and sharing awareness of this kind of stuff. So a lot of this should already be happening, because obviously we're doing this live stream about a week or so after the actual guidance came out. So a lot of this should have already happened, but the key deadline that's coming up is the 3rd of February, which is approximately 12 days from the point that we're going live on this topic. Then talks about CQC and the monitoring. So it explains the powers that CQC have in terms of looking at this and in terms of what they'll be looking for. And effectively, that's confirmation that staff have been vaccinated. And the enforcement part of it comes into play that with the new requirements under the regulations coming to the force from the 1st of April, CQC will use their existing assessment approach and enforcement policy to assess compliance with the services that they regulate. So basically, when you get your CQC inspection, they will be looking at this. Is that clear?
It does. Yeah. Crystal clear.
Cool. And it's recommended that employers conduct a provider assessment on the roles deemed out of scope, but which they may have some uncertainty. So if you have somebody that you're not sure about, so potentially contractors, like we talked about, those kind of unclear elements, as we said earlier, you need to contact CQC because they're the ones that are going to be making the decisions on this. Okay. Then there comes the question of establishing vaccination status, and there's 3 ways you can do this. So the first one is just ask your staff, have they been vaccinated? Can they provide proof of that? Which would obviously be stuff like the NHS COVID app, vaccination pass and stuff, or confirmations through emails and stuff that they've had their vaccinations done and things. Organizations can look this up if they've got their own delivery program they've done in-house. So some organizations like hospitals and stuff probably did a lot of this at the early start, so checking the information there. Or they can check central databases, which is the NIMS one that we talked about earlier and stuff.
How do you feel about that? Because that's an unusual instance, isn't it, of an employer being able to check health information that regards to employees, which is a privilege that employers don't normally enjoy. And it's unclear to me whether the staff have to give consent for that or not, and I'm assuming that they don't.
So according to this guidance, not our opinion, this guidance, it says that they can look at this guidance, the information, because of the statutory powers given to them by government in the Health and Social Care Act law. I guess we would ask staff about their vaccination status for certain things. So, for example, hepatitis B, we would have to ask. It's a mandatory part of working with patient-facing contact and stuff, and other, things like you might potentially ask about measles, mumps, and rubella status if you're doing vaccinations and that kind of stuff, and have exposure to children and things. So, that we would ask the question about vaccinations. But you're right. It's that I'm not sure if employers, well, I can't remember an episode where employers would be able to actually look for that. I think you'd still probably have to inform the employee doing it, but there is a route for them to check if they need to, because they've now been told statutory organisation wise that they have to check this.
Just feels like is this the thin end of a wedge? I guess we're using these powers now during a pandemic, but one wonders what precedents we set. But it is what it is. There we go.
I'm asking this question in the chat and asking it live as well. What do you think, listeners, viewers? Do you think employers should have the ability to look at somebody's vaccination status through the powers that are available through the systems and stuff? If you disagree or agree, so if you agree, thumbs up. If you disagree, thumbs down. That'd be really cool. And let us know in the chat, and let's see if we get anybody commenting on stuff. We have had a couple of comments that have come through already. So Tyrone's mentioned about something to do with acute transverse myelitis during COVID. I think that's potentially identifying some of the potential side effects. Again, we're not going to get into the should you or should you not have a mandate in terms of vaccinations. This is more talking about the guidance that exists to help employers. VCOD has put a link on, but I can't unfortunately link to the link. So
I've had a look at the link, Andy. It's actually interesting. It's an article from the Independent that has just broke this morning, suggesting that the government might pause the NHS COVID mandate, as they call it, I guess also known as VCOD. So that's interesting, and to most, given one wonders if that might happen given the relaxation of Plan B and other rules and the changing messaging that we're getting from the government around vaccination. But as it stands, this is something that is happening, and employers and employees continue to need to be prepared. And there's a window as well. I mean, obviously, if they may or may not drop this at some point in February, but if you're an employee or you have employees, you need to have started them on that route towards having 2 vaccines by the 3rd of February. So I don't think people can wait and see what happens on this one. I think people will have to proceed as if it is going to come into law, and not pause based on that independent article. But it's really interesting, and thanks, Vij, for letting us know.
Yeah, so he's put a longer comment, which I think basically is a part of that article that basically says, although they may rescind it, that they are already basically saying you should be looking at this now, because they may not, which is a key thing. So the next category looks at the legal basis, which we talked about in terms of how they've got the legal powers to mandate this and look at the information and stuff. And then there's also a section on the information governance and how that works as well. We're going to go a little bit further down to the next topic, which I think this was probably the key point I would really recommend people need to be aware of. So I'm going to zoom in a teeny tiny bit so we can make that a bit bigger. There we go. It's just doing it now. Okay, so it is important to note this is not a redundancy exercise. Employers will not be concerned with finding suitable alternative employment. There'll be no redundancy entitlements, including payments, whether statutory or contractual, triggered by this process. So that's basically what it's saying. Yeah.
So let's read between the lines there, Gandhi. So my interpretation is that if obviously normally when somebody ends their employment and it's not a matter of gross misconduct or something like that, then they're often entitled to certain entitlements on exit, like redundancy pay, for example. And this is saying that doesn't apply, which I think is quite a big thing.
It is. And that's the the government's interpretation of the law and stuff. So again, not us, be very clear on that point. And it does talk about, however, that they are encouraging employers to look at alternative options for people who still choose not to have their vaccination. So in terms of redeployment or other kind of things that may happen, but again, citing that this is not a redundancy exercise, and look at health and safety and that kind of stuff. It definitely highlights about communication being a priority. So in terms of what you have to do, the people who are not relevant and those who are, addressing vaccine hesitancy and the consequences of not meeting the deadlines in time as well are commented as well. So then it talks about the formal process, which I guess is probably the key part many people who are uncertain about what they want to do, and also employers probably want to know about. So the first one it says is to talk with unions. So to engage with the, members of staff should be able to contact their local union representatives and have a discussion with them. And then step 2 goes into a formal review process, which starts from effectively the 6th of January, which is the communication phase, but officially then comes into play from the 4th of February if you have not had your first dose. And that's basically to identify those who may not want the vaccination. And if they still are feeling that's not the route they want to take, then obviously starting this process early. So, Andy, go for it.
I was going to ask the question, do we know where the various sort of trade unions sit on this question? Because if I was a vaccine hesitant nurse and was facing, it might be quite difficult to redeploy me to a non-patient facing role, one imagines, as a nurse doing perhaps certain roles that might be my job. I might be facing a redundancy situation. I would turn to the RCN. We probably don't know the answer to that question, and I might just have a quick look on their website. And if anyone does know the answer, put it in the chat. But
feel free to have a look, Andy, either RCN or BMA. I do know the RCGP's position on this after speaking to the chair, Professor Martin Martin, on Tuesday evening for the Innovate live stream, was that the RCGP does not support the mandate, and that clinicians should have the right to choose. So that was the RCGP's perspective. I hope I'm quoting that right, because it was a late night one, but feel free to watch the live stream if you want a confirmation of that either way. But yeah, I'm not sure what the BMA's perspective is, and I don't know what the RCN's perspective is either.
I'm on the RCN website, and they do have a statement. I'm gonna just stop short of paraphrasing it, because I haven't fully absorbed it here. But they're sort of expressing concerns about the mandate. I'm not sure they're either on sort of the absolute position they would take, when dealing with cases, and I'm sure they might sensibly fall short of that and deal with each case on a case-by-case basis. But they have concerns about the regulation. I think it might be interesting for people to delve a little bit deeper into that statement and that of the other trade unions. But it's an interesting question, isn't it? What sort of, will people be backed up by their trade unions or not, and to what extent? Interesting.
So my understanding from reading this document, and that's purely off reading this document alone, is that the trade unions can obviously support their members in terms of representation of these meetings and stuff, but the direction of travel is very much that if redeployment is not an option, then you are looking at dismissal from the role, and that would not be, as we mentioned earlier, with things like redundancy and other options available to yourself and things. And that's emphasised, I guess, in this green bit. So during this formal review process, line manager will need to advise staff if the above options cannot be facilitated, possible outcomes, the individual may be dismissed from their employment within the last day of employment being the 31st of March 2022, or after, depending on contractual notice period, if remained unvaccinated or have not disclosed their vaccination status.
I wonder if, I suspect a lot of conversations will be had around whether or not it's possible to redeploy. I suspect that's what a lot of these cases that might emerge will hinge upon.
So we're going to get into that. So step 3 is then the formal meeting. So this is from the 4th of February for anybody who has not either disclosed their vaccination status or who has not had their first dose or second dose, is allowable a bit later on. Then there's a process by which that looks into in terms of notice periods and looking at future prospects. There's a comment on the Equality Act of 2010, whether this applies and stuff. And if you want to have a look at it, the link is in the show notes, but this is basically the page we are not going to go through this document. It is another 22-page odd document, but basically this is the government's analysis of the Equalities Act, and basically it says that this guidance does not breach it from their perspective and from the legal perspective of it and stuff. So just to be aware that that process has been looked at, apparently.
But we've had some further engagement from Vig on this, Gandhi, in the chat.
So I think he summarised, our point that we made earlier, that and the last part, that if you're told that staff have to leave as a result, they have no recourse to legal action against their employer. Because they're following the law, basically. So I know some people are very. I know with the discussion I had with Kemet FM, a lot of people seem to be directing a lot of their angst at the employers over this process. Important to remember that this is a change in law that has happened. The employers are doing what they're being told to do as per law. So it's putting everybody in a very difficult situation.
Yeah, absolutely. And Vig makes the earlier comment around. I was just going to reflect on the earlier comment, which we've sort of said we won't get into. I wonder if there might be time at the end, but just about it's a difficult line that society is walking in terms of balancing rights of individuals against individual right to autonomy around their body and their functions. It's really difficult. So just acknowledging that we're making those comments, and I agree, it's a really, really difficult area.
So next we get into the concept of what about redeployment. So this is I think the part that many employers will find really challenging to understand and interpret. You just had a walk by, Andy.
I know.
So reconfiguration of roles. Employers will need to consider whether it's possible, reasonable or practicable to reallocate patient services facing duties among existing teams to enable an individual to continue working their current role whilst they remain unvaccinated. And also it makes a reference that existing patient pathways, care and experience should not be compromised if staff are not able to be redeployed or in the process of redeployment. So just reminding everybody that this is not a reason that you can say that you can't do certain things. It does also say that if you feel that you can't do things, you need to let them know. So there's no point waiting for it to be a retrospective look if you have to be proactive on this as an organisation. And in terms of redeployment, so it talks about the various different principles and frameworks that are set out. So basically, organisations should identify roles that don't engage patient facing opportunities as part of their possible redeployment for the individual. But it also highlights that this may not be possible. And then that's a real challenge, I think, both for the individuals and for the organisations as well. It talks about temporary redeployments. This could be for short-term issues. So like we mentioned earlier, the pregnancy in women, or if there's medical exemptions that are on a temporary basis. This still is then with a view for those temporary processes finishing, and then that person being, coming back into the normal workforce. And also for those, for example, people who are on sick leave and that kind of stuff, looking at that as well. But this is probably the key part if we're looking at permanent redeployment. So responsibility of the employer to ensure the recruitment selection process is carried out fairly, to work with organisations such as other organisations like ICSs. So this is, I guess, for people who are involved in ICS, CCGs, other kind of roles and that kind of stuff. There's redistribution from there. And looking at alternative opportunities to support the individual if there are any within the organisation. I guess in practice, that's going to be quite tricky because most practices are obviously small enterprises. So most people will know if there's a vacancy or not. But obviously that would apply to things like hospitals, potentially, CCGs, ICSs, all those kind of larger organisations and stuff, potentially.
Yeah, I think it's really difficult for everyone, isn't it? But in particular, the smaller organisations like GP practices, where the opportunities to redeploy people to non-patient facing activities is less, one presumes, than it might be in a large NHS trust, for example. It's difficult.
Yep. It then talks about employers should support employees in terms of finding new different roles. But also it does comment here about, in the last part of that section, that there should be no preferential treatment given to people who are being redeployed due to VCOD compared to other people who are being redeployed for other reasons that may not be related to the vaccination status and stuff. So there's no preference on this basis, even though there is an acute timeline in place. Talks a bit more about the management responsibilities, and a lot of this focuses around communication and support to the person if they're choosing not to have their vaccinations. And yeah, that's pretty much the basics of those 4 paragraphs. And then for the employee to the responsibilities of the employee to remain engaged with the process and have discussions, to communicate changes in their vaccination status. It's the employee's responsibility to do that. It's not the employer's responsibility to make sure that happens, and to look for alternative options if they feel redeployment or leaving the dismissal is the likely option. And to recognise that redeployment opportunities may change current working arrangements, inclusive of hours, pay, and place of work, impact upon professional registration if applicable. What are your thoughts on that one, Andy?
I was just drawn to a comment actually. Vaishali Nanda is just commenting about where people are redeployed, they still have interactions with other staff members. So there's only a limited impact on the reduced risk, I guess. I suppose it does increase the distance they have to patients. For an infection to pass from them to a patient, it would have to go through another staff member, which I suppose does reduce the risks there. But they'll still have an impact on infections within the staff group and the ability of the practice or the organisation to continue to deliver an effective service. So I think you're right. There's a relative reduction in the risk only.
Yep. I guess my understanding is this direction is being made up purely on the basis of the impact on patients. So that's why it's relating to patient contact, not necessarily staff contact. But it's a valid comment about transmission and routes. But I guess the premise is that the staff should be vaccinated. So that should reduce the steps to impact and stuff as a result of it.
But yeah, just coming back to the highlighted paragraph on the screen, I think that's quite significant, isn't it? So it looks like employers have the freedom to offer redeployment that doesn't provide the same work on the same terms, essentially, which I think is interesting. This document is seeking to give employers a lot of freedom and power to make sure that patients will not come into contact with unvaccinated healthcare workers, I guess. And they're doing everything they can to make it happen, I suppose.
Yeah, I think that's the key part. I think that says to me is about hours and pay are the 2 key things. Place of work kind of comes into effect if they're not vaccinated and they can't have contact with patients, and place of work may change. But pay is another part of it that I think many people will have potentially an issue. It does state somewhere else, I can't remember if I highlighted or not, but protected pay in terms of pay bans and that kind of stuff also do not apply. In terms of pay awards and that kind of stuff. So if there are changes that need to be made because of redeployment, they're not protected and stuff. So important to be aware of that as well. Where are we? Next, it was recruitment selection. So look at redeployment options. This again talks about support and what should be looked at and shouldn't be looked at in terms of suitable vacancies. So not looking, I think Vishali mentioned about finding other vacancies around patients. So possibly, can you redeploy them somewhere else where there's patient service contact? The answer is no. That's kind of pointless. And the staff will need to apply for those redeployment opportunities as well. It's not that they're automatically slotted in, because obviously if there is a job vacancy, they may have to reapply in certain search situations and stuff. Any questions so far, Andy?
No. I think we get into some standard territory about respecting, equality, diversity, and so forth, which is important. And we shouldn't have to state those things, but those are obviously stated within the document.
Yeah. So I did highlight the bit about pay protection. So while the redeployment is undertaken on the purpose of VCOD framework, individuals in the scope of regulation are not eligible for pay protection of their basic salary or additional earnings, on-call payments, unsociable hours, etc., should they obtain employment at a lower band or grade to the one they currently held with a different working arrangement. Fairly clear.
Yep.
Support for staff, so it talks about that if needed. And then the last main section that we have here is the termination of employment on the purposes of VCOD. So I guess this is where some people will be looking at in terms of what this means for them. As previously detailed, the fair reason for dismissal will be on the grounds of a contravention of a statutory restriction, or in the alternative, some other substantial reason. So this makes reference to the fact that this is a statutory change in the law, and that if it's not, if you're not complying with the regulations, then it's a breach of that, and that's why dismissal is therefore an option. What do you think, Andy?
I guess we're beginning to restate what's already been stated, I suppose, haven't we? Yeah, but I mean, these statements are helpful for the employers, and they're sort of providing the type of protections that VCOD was alluding to. You know, it needs to be clear that there's no legal recourse against the employer, particularly when you're talking about GP partnerships who have, you know, exposure to the liability of business activities, and you know, HR can be a difficult area. No one wants to go to an industrial tribunal over this sort of thing, so that sort of clarity is helpful.
It talks about the process of the discussions if you're having them. So initial inviting them in for individual discussion, one-to-one supported conversations, and other discussions possibly with the unions and things, and consideration of alternative roles. And then the process for that happening, and if not, then dismissal notice will come into effect from the 31st of March if that's the case. Notice of dismissal should not be issued before the 4th of February and should not expire before the 31st of March, however, inclusive of those dates if that happens afterwards. And then it talks about payment in lieu of notice and stuff and things that happens. And that's that document. The final one I said I would mention to people to have a look at is the frequently asked questions. So this is only a 9-page document. If I'm being honest, if you don't want to go through the whole 22-page document, which I can understand most people won't, this is probably a really good one to have a look at, and a really good one to share with staff and other members of your organization to understand what the purposes and everything is. It has it really clear in terms of details. Who does it apply to? Who's exempt? The guidance that's there, what you can do, what this means for you as a worker, and also what it means for an employer. What the potential exemptions are. We talked about this earlier in terms of medical exemptions. Key point it makes of this is that if you are thinking that you have a medical exemption, then you should be ringing 119. You should not ask your GP. I guess I'm going to put a slight plea out there for myself and Andy on this one, because it's GPs can't contravene this until you've done the relevant steps, which is contacting 119 first.
You know something, Andy? I've had a few conversations with healthcare workers over the past few weeks that relate to this being applied by their employers, and they've been quite interesting conversations actually, because the outcome in most of the situations has actually been that the person proceeds and gets vaccinated. You know, they've asked, do I have a medical exemption? And the answer is often no. Those are very tightly defined and only applied to actually quite a small number of people, and you don't, I'm afraid. But you know, but why don't you want to get vaccinated? And often they just haven't had an open conversation about vaccination to that point. And actually, the few conversations I've had have resulted in them saying, actually, you know, I think I will get vaccinated. Actually, thank you for the conversation. So just very interesting, and that's my anecdotal experience. Have you had any experience of people coming to you, Gandhi?
I have had a few patients come and see me on this basis. We've discussed about, you know, what the medical exemptions are, whether they apply to them or not. As you mentioned, the reasons for not having vaccination are very small. It is pretty much either you're allergic to the components of the vaccination, which is actually highly unlikely for most people, or you've had a significant allergic reaction to the first dose. The only other exemptions are for patients, for example, with significant learning difficulties or autism and that kind of stuff, where they can't, you know, manage the process and discussion effectively in terms of weighing up the pros and the cons of it. So, you know, those are pretty much the only reasons for medical exemptions. And, you know, some of those discussions, I think you said, like, gone in a positive way in terms of the person understanding the reasons and then making a decision what's best for them at that point. I must have unfortunately, I've had some fairly unpleasant discussions with people who have accused me of doing various things. Unfortunately, it's not my responsibility or my ability to change. We just obviously reflect the information that we have on the person's health and stuff. And you know, I can't lie. That's the key thing, which is what I have been asked by certain patients to do. I've been asked to lie on the forms, and I said, I'm really sorry, I can't do that. And that's a really difficult conversation then.
Yeah, of course.
Yes. I guess the other question that some people may have: what if I've had tested positive for COVID? How does this affect the timeframes? So it does mention this somewhere here. Here we are. So if you have tested positive, which obviously, unfortunately, with Omicron being a lot more transmissible, this may have happened to many staff who are considering it. That does put you into the temporary exemptions criteria. So as most people might be aware of, if you have tested positive for COVID, you can't have the vaccination dose until 28 days after your test was positive. If that's the case, you need to share the result with your employer, either proof that you've had a positive test, and very clear, it's probably going to need to be a PCR test because you need confirmation in some form. So an LFT test may not be enough. It may still have to have a positive PCR test. And then you get effectively a 42-day reprieve in terms of when you have to have then had your first dose by from the date of your positive test. So that allows 28 days for the period you can't have your vaccination, and another 2 weeks effectively to get the vaccination sorted in that time frame for your first dose. If not, then the guidance and the regulations come into effect. So as I mentioned, really have a look at the FAQs. It's got a lot of information. It even mentions about what about volunteers. Volunteers, the guidance applies to. Trainees, students, it applies to. Basically, if you have any contact with patients, this guidance applies to you, long and short of it.
So, yeah, I think the FAQs are much more accessible than the main document, and I think the main document serves that purpose for, if you do have a member of staff as an employer that it applies to, or if you're a member of staff that this applies to, then I think you're going to be wanting to look at the main document to guide you how to proceed, from a legally safe perspective. If you're just looking to implement it across your staff and answer people's initial questions, and the outcome is that people do get vaccinated and you're not looking at any significant issues within your organization or employment, then you probably don't need to go as deep on the main document, I guess.
Definitely agree. So I think at this point, it may be worth seeing if anyone's got any questions from the chat and comments and stuff. I guess the other point that probably would be worth us discussing, which we may be able to have some ideas on, what are the redeployment options in general practice in particular? So I don't know, is this something you've had to think about at all, Andy?
Well, I mean, we're fortunate enough, I believe, not to be sort of facing these questions within my own practice. So that's really, really helpful. But we have talked about it, and it's really difficult, actually, because we're generally based in a building where the way in and the way out of the building is the same way that patients come, and people have to walk through the waiting room in order to access the bits of the building where they work. There is an office area where there isn't patient contact. That's probably the only place within our premises where there is no patient contact. It would be really difficult. That person could not go to the toilet without bumping into a patient, etc. So I think technically there aren't really many redeployment options. Remote working has come into play, hasn't it, since we've been working with COVID-19? So in theory, it might be possible for a receptionist, for example, or an administrator to function from their own home. This would be a really unusual, a new thing to be happening, for someone to be permanently doing that for the rest of the time that they are employed with us, which would be what has to happen. There's no indication that this requirement will be removed after a certain period of time. So the interesting point for me is actually how far we have to go in order to redeploy. And I think the document indicates that actually the expectation is that the redeployment is within kind of usual activities that happen, usual pathways and processes. So I don't interpret that to mean that we would have to create a remote working role for somebody to redeploy into. That would be my feeling. I don't think that the expectation would be that we go that far. If that activity is already happening within your organization, then there might be an argument, I think, from the member of staff that they should be redeployed in that way permanently. So I think it's really tricky, isn't it? We have had some admin members of role working from home for a period of time when they've had COVID infection, but that hasn't been permanent, and I don't think we would ever want to make that permanent, because that member of staff will become isolated from the team, etc. How about yourselves, Gandhi? Do you have any thoughts on redeployment?
So I guess in terms of our practice structure, it's possible that somebody could have a place in the practice estates where they could work without having any potential contact with patients, and that would only potentially then happen if there was something like a fire alarm or something like that, where everybody had to evacuate the building, because we do have a separate entrance that staff could use, and things. But you're right, it makes a challenging situation because there's always that possibility of it happening. And would that satisfy the requirements? Because we don't have a separate space that's not the building, not where the patients come. It's just a separate entrance and stuff. So there is that element of things. And I think if there are organizations where they have, separate estates where people can work without any potential contact with patients, okay, that might be a possibility. I think the concept, like you mentioned about remote working, whilst that's a possibility and something that many people are looking at as part of their role, either temporary, because obviously we've seen that with COVID isolation and stuff, or, more longer term or part of their work-life balance, that might be possible. However, and I'm going to bring up Vaishali's kind of comment, we've had to consider for a secretary if they can work from home. However, our HR advice is that we have to give that option to all admin staff who they can then work from home. And I think the problem that you then have in that kind of situation is the capacity for the business itself to then deliver its core functions. And we saw earlier in the guidance that whatever policies and stuff you put in place should not also negatively impact your other members of staff. So we saw that in the guidance. So if whatever you're having to do then negatively affects other staff who are vaccinated and who this doesn't apply to, that's also not applicable, and you may not have to do that.
The thing that I was interested in, Gandhi, was how far organisations have to go down the lines of looking for redeployment across the ICS. I thought it was interesting that was mentioned. And I suppose it's to what extent your work is integrated with ICS work, I suppose, because the ICS is just a collection of different discrete organisations. So I was just trying to get my head around what the implications of that meant. Do I need to look for a redeployment solution for my secretary somewhere else within the ICS? That sounds very, very complicated, and I don't think that's practical, really. And but it was interesting that the ICSs were mentioned in that way.
And I think it's going to be difficult for general practice to be involved in that, because we're probably not going to be included in some of those wider management discussions and stuff that happen. I think the other part that's really challenging then as well is the longer term implications. So if this is long-term guidance that sticks, then important to note that what do you do in a couple of years' time if, for example, you were to have a patient engagement event and that member of staff is then being asked to help support that? Are you going to remember that this has happened? You're going to have to then turn around and say that actually can't do that. You can't be involved in that, even though in community life, in their personal life, they may be going out and meeting people and patients and that kind of stuff. Actually, from an official capacity, that's going to have an implication in 2, 5, 10 years down the line, potentially, depending on what obviously the guidance still is at that point. So there are other factors and stuff that come into play.
We've had a direct question, which I think we are probably not placed correctly to answer or give definitive guidance on. My instant reaction is that's probably not a good idea, because that's not the named system within the document. So that might place the employer on shaky ground, I think. Take further guidance, but I wouldn't do it without being really sure that was acceptable.
So for our podcast listeners, the question is, are we allowed to look up IMS status via Pinnacle? Although Pinnacle is the interface system that puts the information from practices into the NIMS, I don't think it's the same platform they're talking about in the guidance. And the people who have access to that element of the back end is meant to be a very small list of people within organizations. So it may be practice managers and stuff, but ideally they should have already explored that either by asking their existing staff about vaccination, and if they've said no, then there is the option of going through that route at that point. But I would not definitely be recommending people look at that on a regular basis at all. So please don't, and check first. I think is our answer to that, as Andy mentioned. I guess remote working is probably something we probably are qualified to talk about in some way, Andy, given how much we talk about it. I mean, for clinicians in particular, it's an interesting prospect, isn't it? Because there is the possible route of doing remote only work. However, as far as I'm aware, that's only really established for GPs. For all the other healthcare roles, that's going to be a bit more challenging.
I think so. I mean, we've had people, whilst they've been unwell with COVID, doing remote telephone clinics, and where there's a need for face-to-face assessment of somebody, then that has been done by another clinician and they've been booked in for that. But it's always been clear that that's a temporary position, and that's not a credible permanent role. And I think in in job descriptions, and I'm not sure about this, but I imagine it's at least assumed that face-to-face assessment is something that would be provided by a GP to the employer. That they can use that if the employer needs that to deliver a service. Yeah, it's tricky, isn't it? I think remote work does throw a curveball into this redeployment question. To be honest, I was just going to. Well, we've got a little bit of time left, Gandhi, and not to stray too far into these philosophical areas, but I was just reflecting kind of how far we've come over the last 2 years. There were times when the thought of a vaccine passport to go to a sports event was way too far for the public and potentially ourselves if you were having that conversation with us, and that's become something that's happening. The question of whether vaccination is a requirement of working, of deployment, could be something that was done, and whether that was morally right. If you'd asked us all some time ago, we might have given a different answer to the sitting on the fence that we probably give now. And that's definitely coming to place for social care workers, and now it's coming in for health workers. This is it's moved. The position on these questions of bodily autonomy have moved and shifted, haven't they? And I know we're being careful not to say whether we agree or disagree with legislation, but I'm just wondering what you think about that.
I think it's opened up a lot of questions for many people. Interesting, although we didn't cover this in the guidance, one of the things it does state, this guidance doesn't relate to seasonal flu vaccinations. However, what it does say is that will be reconsidered closer to the time to the 22-23 vaccination program. So whether they bring in flu vaccinations into this is a potential possibility, I guess. And that'll be interesting to see how people perceive that one, because that is a vaccination for a similar but slightly different reason. And obviously flu is something that has been established and going around for many, many years. I mean, technically COVID is a type of flu. It's just a different strain of flu that's obviously a lot more impactful, shall we say, on our daily lives.
I mean, we've always needed certain vaccinations like hepatitis B for doing certain types of procedures and roles within healthcare, and where that's not possible or there's infection, etc., people have needed to be redeployed. So there's precedent for this sort of thing, and no one ever really questioned that in the past. Or maybe they did when it came in, but it's been in place ever since I was at medical school. So there's sort of precedent. I think it is a really thorny, difficult area, and I think for me a lot of this depends on the context and the risk, the risk benefit. And obviously we've brought these things in during a global pandemic that has affected and there's been a lot of loss of life. So it feels like these things are necessary now, and they might not have felt that way in the past, and things change. I suppose it's all relative. It's difficult.
It is very much so. And I think on that note, we're going to have a look at what's coming next. So thank you, first of all, everyone who's joined us live. Especially thank you to Stephen, who's a regular viewer of ours, and he makes comments quite frequently. And so he's saying, good morning, guys, and good topic. So thank you for that, Stephen. If any of our viewers do have any particular topics they want us to have a look at, let us know. Send us a message, stick it in the chat, send us a contact on social media, whichever platform you prefer. As most people know, I'm on almost every single one. Andy's around on Twitter and LinkedIn and stuff as well. We are looking at some really exciting content coming up in the next few months for all of you, particularly if you are PCN based, particularly if you're a clinical director. We've got some really specific content coming out shortly for you that's going to, we think, be really valuable to PCNs and that kind of stuff. So definitely keep your eye out for that. We will be back doing more of this kind of stuff in terms of documents and stuff. I'm sure there's going to be more documents coming out at some point as ever, so we can discuss those and things. And obviously here to help support all of you working in primary care as best as we can as we continue to try and tech enhance your primary care and learning. And we will catch you in the next episode. See you later.